Next up, we have Danny Gale. Danny Gale is a consultant nephrologist in UCL. He's also a clinician scientist, and he was responsible for defining a disease which we're here today one of which we're here today to discuss, CFHR5 nephropathy. That's not all he's going to discuss. He's going to discuss what your kidney biopsy tells us, and hopefully he's going to define what all these difficult terms mean for us. Okay, thanks, Danny.
Thank you, David, and thanks for the introduction. So I'm going to start off by throwing all the letters of the alphabet at you. And this is the sort of slide title that will scare medical students. So I'm going to try and put it in some sort of context with what people in this room will have experienced, and hopefully try and make a complicated subject understandable. So I'm going to talk first of all about what actually is a kidney biopsy. I'm going to briefly discuss how it's processed, how we look at it. Then I'm going to talk about the changes that we see that lead to the diagnosis of membranoproliferative glomerulonephritis and C3 glomerulopathy, and how we then subdivide C3 glomerulopathy into dense deposit disease or C3 glomerulonephritis. And I'm going to briefly touch on why some of these diseases occur. So what is a kidney biopsy? Well, the principle is taking a very small piece of tissue so that we can look at it under a microscope. And there's nothing really magical about the piece of tissue, and it's just like looking at, it's a way of looking at an organ that is hidden from view. So what tends to happen is the patient will lie on their front, an ultrasound probe will be used to identify where the kidney is, and a very, very fine needle is passed down to take a piece of kidney. And this is what the kidney looks like to the operator on an ultrasound probe. So what is actually taken? Well, this is a picture of the piece of tissue that is taken. So this is actually a piece of a person's kidney. And I've tried to give you some idea of scale with a 1 penny. So it's a really tiny piece, less than a centimetre long normally. And that's, in fact, what kidney looks like to the naked eye. Now, if you look really closely, you can sometimes just about make out little red spots in the kidney biopsy section. And those little red spots that are really too small to see unless you really get up close to the biopsy are the filtering units, or the glomeruli, in the kidney. So the kidney shown here has about 1 million of these filtering units. And when we do a kidney biopsy, we take around 10 to 30, depending on the biopsy, out of the patient so that we can look at them. So what do we do next? Well, the piece of tissue is then fixed, which is basically pickling in formalin, and that makes it a bit more stable. And then we embed it in wax, paraffin wax, in order so that we can then slice it up and look at it in great detail. We slice it very, very thin indeed. The measurement's about 2 microns. We mount it on a slide and then put special stains on it that have a colour to them and bind specific proteins. So starting with that, we'll then slice it very thin and stain it, and you get a piece of tissue that looks like that. And if you put a light behind it, you can see the architecture. And if you look at it under a microscope, you can actually see a cross-section of a glomerulus, which is shown here. And you can see that it's roughly globular, and it has a complex network of what we call capillaries, which are very, very, very small blood vessels running through it. And that's really the clockwork that allows the filtering of the blood to take place. And of course, you've got 1 million of those glomeruli doing the job at the same time. So what exactly is this clockwork? Well, each of these little loops is one of the tiny little blood vessels that form a network in the glomerulus. They're supported by these supporting cells, which we call mesangial cells, and they're coated with a specialized surface that allows the filtering of the blood to occur. And that's the biopsy picture of a whole glomerulus. And if you zoom in, you can actually see very carefully the loops of the capillaries. Now, if you look in even more detail at these loops, you can use a special type of microscope called an electron microscope. And an electron microscope is a microscope that, instead of using light waves, uses electrons in order to see the the tissue. And the advantage of this is that you can get a much greater resolution than is possible with a light microscope. And what you're seeing here is one of these capillary loops. So it's one of these things that comes from a glomerulus, that comes from the kidney. And you can see the architecture of the actual filtering unit of the kidney here. So you've got the cells on the outside of the loop, which we call podocytes because they got feet. There's the structure in the middle called the glomerular basement membrane, and this is the sort of scaffold that holds the capillary loop and keeps everything functioning properly. And then on the inside, you've got that endothelial cells, and endothelial just means on the inside of blood vessels, because these are the cells that line all the blood vessels of the body, but there are specialized endothelial cells, specialized blood vessel cells that line the capillary loops in the glomeruli of the kidney. And over here you can see some of the supporting cells, the mesangial cells that support the structure. So the kidney isn't just composed of the filtering units, the glomeruli, it's also composed of tubules, which Edwin explained earlier, sort out the balance of salt and water in the body. And in a healthy kidney, you'll see that there are glomeruli, but all the stuff between the glomeruli is composed of other tissues, including the tubules. And a healthy kidney will be ram-packed full of tubules that are back-to-back and form this sort of mosaic of tubes. And you can see each of those as a tube that's been sliced through. Now, when we do a kidney biopsy, the first thing that we look at is the sort of architecture. We can see the glomeruli, we can see the tubules. And if a person has had kidney damage for any length of time, then the tubules gradually disappear. And that's presumed to be because as the glomeruli are damaged, they fail to produce the urine and the tubules just wither away. And what you see is areas of scarring or atrophy. And that's a very useful thing to see on a kidney biopsy because it gives the doctor some idea of whether the changes in the glomeruli are likely to get better or whether the damage that's been done is likely to be permanent. And one can assess the rough percentage of rescuable kidney by looking at the degree of scarring in the tubules. But for MPGN related diseases, this is just a sign of the damage that's taken place. It's not a feature that allows us to tell exactly what the mechanism is, and for that we concentrate on the glomeruli. So what are the changes that define MPGN and dense deposit disease and C3 glomerulopathies? Well, so what I've shown you previously are the normal glomeruli, where you have these open capillary loops. You have a few cells that are supporting the kidney. But in MPGN and related conditions, there's really two main features that tell the doctors that this is what the diagnosis is. The first is that there's increase in the number of cells. So the supporting cells, instead of just being maybe 3 or 4 in each region, they multiply. And there are more cells there than we normally expect to see. And along with that, the pinkness, so that's just a representation of the stain, but the pinkness of those regions is also increased. So you have a denser, more cellular glomerulus. In addition to that, you have thickening of the capillary walls. Okay? So one of the reasons that this disease is sometimes known as mesangiocapillary glomerulonephritis is that on the light microscopy, the kidney biopsy, what you see is mesangial, that's supporting cell expansion, and capillary wall thickening, so mesangiocapillary. And that's what mesangiocapillary glomerulonephritis actually means. Glomerulonephritis just means inflammation of the glomeruli. Now, across the Atlantic, exactly the same biopsy features were called membranoproliferative glomerulonephritis. And what that's alluding to is the glomerular basement membrane, which lines the capillaries, becomes thickened, so membrano, and proliferation just means multiplication. So it's the membranes and the proliferation is seen. So the two terms, MPGN and MCGN, are completely synonymous. One is just an American term that's now become more commonly used in the general medical community, reflecting the size of America more than anything else. And all it represents is the changes that are seen on the light microscope. And you can do other stains. I'm not sure how well this has come out, but if you put a stain on that specifically stains for the glomerular basement membrane, this is with silver, which binds to the basement membrane, you can actually see reduplication, where there's, instead of a single line, there's a double line, a tram track appearance of the basement membranes. So, and these biopsy appearances are actually seen across a range of kidney diseases. So, these exactly the same changes might be seen in patients with lupus. They might be seen in patients with IgA disease and other diseases that aren't necessarily relevant to what we're talking about. And that just simply represents the fact that what the changes that are seen on the biopsy are described by those terms. Now, over time, as more diseases have become better understood, the term MPGN has been left to reflect those cases in which these changes are found, and in which there isn't another disease that we can put our finger on that's causing it. So we know that people with MPGN don't have lupus, because if they had lupus, we'd call it lupus nephritis with appearances of MPGN. So when a patient's given a diagnosis of MPGN or MCGN, all that means is that these particular biopsy appearances are seen, and that they don't have an obvious cause that we can say is responsible. So in the whole world, most patients with these appearances actually have chronic infections. So particularly in African countries like Egypt, where schistosomiasis, which is a tropical disease, is found, lots of people go on to develop MPGN. We don't really call it MPGN because we call it schistosomiasis-related kidney disease. But the changes in the kidney are identical or indistinguishable from those that are seen in MPGN. So you'll also have heard about electron-dense deposits. And these are important because these are the things that we can see on an electron microscope. They're very, very small, that tell us a bit about the disease. So what I've got here is a diagram of a normal glomerular capillary loop. This is exactly the same thing that I showed you a few minutes ago with the electron microscopy. But in MPGN, in some cases of MPGN or C3 glomerulopathies, and I'll talk about the difference in a minute, you see this black material accumulating, which you can see on an electron microscope. Now, you can't see it on a light microscope. You have to use an electron microscope to see it. And these are called electron-dense deposits. You also see on the electron microscopy that the supporting cells begin to creep into the membrane, and that's probably what's accounting for the thickening of the capillary walls that you see on the light microscopy. And most of the time, the electron-dense deposits are scattered around the inside of the basement membrane, but sometimes they're scattered around the outside of the basement membrane. There are some diseases for which this is really characteristic, and doctors and pathologists like dividing things up by what they see, but in principle, the important thing to remember is that the dense deposits can be inside the membrane, they can be within the supporting cells, or they could be on the outside of the basement membrane. They can also, sometimes, instead of being discrete deposits on the inside of the basement membrane, they can form a really dense, ribbon-like deposit actually within the center of the basement membrane. And this is dense deposit disease. So when we see transformation of the basement membrane into this dense material, and it's normally very dense, much denser than we see in the previous slides that I showed you, that's what we call dense deposit disease. So just to compare it with the discrete electron-dense deposits, I can't really see this very, I hope you can see that there's sort of blackness on the inside of the basement membrane. And this is a fairly subtle distinction, but what we've come to appreciate over time is that dense deposit disease forms a very discrete spectrum of diseases, or there is a discrete number of causes for dense deposit disease that make this a very, it's rare, but a very discrete range of problems that actually give rise to it. So we can also look at the deposits in more detail. And this is a slide almost exactly the same as the one that Matthew showed you in the last talk, which shows lighting up of C3 in the glomerulus. And when we do a kidney biopsy, on all kidney biopsies, we use special stains like this to light up components of the glomerulus to find out what's in there. And the things that we look for, there's really two things that we look for. The first are antibodies, so those are the missiles produced by the immune system to kill infection. And the second is complement C3. We do other things as well, but those are the two really important things. So if we see both antibodies and complement on the biopsy using these special stains, if they're both there, then we infer from that that the antibodies are being produced and that they're causing complement to be deposited in the kidney. And in that situation, we would look for a cause of antibody production. So if there's a chronic infection, for instance, lots of antibodies are produced to fight the infection, lots of the missiles are made. They attack the infection, but they also, because they're filtered through the kidney, they also end up in the kidney and they activate complement there. And that's why chronic infections can sometimes cause glomerulonephritis. Likewise, if there's an autoimmune disease where the body is making antibodies against a part of itself, lots of antibodies are made, and the risk is that they then end up in the kidney, activate complement there, and cause disease. And that's the sort of thing that one sees in patients with lupus nephritis. But if you see complement there without antibodies, then you can't say that it's antibody production, that it's an infection or an autoimmune disease that's causing the kidney disease. It must be something wrong with complement itself that's causing complement to be deposited in the kidney. So that's led to us dividing up these kidney diseases according to what we think the likely cause is. So MPGN is really what the light microscopy looks like. Okay, so any of these diseases can cause those light microscopic appearances, and that's the sort of broad category. But the important thing is whether antibodies and complement are deposited. So if you see both antibodies and complement, and the light microscopic appearances of MPGN, sometimes known as MCGN, it'll normally have this type of electron microscopic appearances where there's discrete electron-dense deposits. We call that MPGN. You may be able to detect increased antibodies in the circulation, but sometimes you can't. Sometimes all you can say is there are antibodies, we know there are antibodies because we can see them on the kidney biopsy. We don't know why they've occurred, but they're causing this kidney disease. And in that situation, the diagnosis is referred to as MPGN. If you see complement but no antibodies in the kidney biopsy, the light microscopy might look exactly the same. You might get the same expansion of the supporting cells, the same thickening of the capillary walls. Then we call this either C3 glomerulonephritis, if there are discrete electron-dense deposits, or dense deposit disease, if there's dense transformation of the basement membrane. Okay, so the light microscopy appears similar, but the electron microscopy is how we distinguish them. So you can see that if you have just got electron microscopy and you see this dense transformation of the basement membrane, you can make the diagnosis of dense deposit disease, and you very seldom see significant antibody deposition in patients with dense deposit disease. You can't ever say never, but really it would be extremely unlikely. So together we call these conditions C3 glomerulopathies, and that's because we think that it's the C3 deposition that's really important in what's causing the disease. So the C3 glomerulopathies can have the microscopic appearances of MPGN, but we don't call it MPGN, we call it C3 glomerulopathy, but we can divide that into C3G and dense deposit disease. And this division is useful because the causes of these diseases are different between different patients. So Matthew's talked about complement, and I'm just going to put this in some sort of context with a kidney biopsy. So what you can have is antibodies, the missiles produced against an infection or produced against the self if there's an autoimmune disease. And this activates the classical pathway, which Matthew mentioned, which switches on C3, leading to activation of C5 and attack. If you have infection or autoimmune disease, then more antibodies are produced, the classical pathway is switched on more, and this leads to the terminal pathway being switched on more, and you have damage to the kidney. You might get damage to the kidney and MPGN. So it's antibody production, activation of complement, damage to the kidney, and you see the antibodies and the complement in the kidney. Now, C3 can also switch on itself, and that's called the alternative pathway, and this is regulated by these factors, factor H, factor I, various other proteins that we're only just really beginning to understand, and this regulation seems to be controlled by other genes, the factor H related proteins. And if you have deficiency of these genes, so if you're born without any of, with a mistake in the gene for factor H or factor I, this allows the alternative pathway to switch on and activate itself and cause damage. And it doesn't need any antibodies there to do that. It's just doing that because there's lack of these regulators. And similarly, very rarely an antibody can occur that instead of depositing in the kidney and switching on the classical pathway, it actually binds to the alternative pathway itself. So it's an antibody that binds to activated C3 and switches on this alternative pathway. And that's called a C3 nephritic factor. And C3 nephritic factors, or changes in complement genes, are frequently identified in people with C3 glomerulopathies, which might be dense deposit disease and might be C3 glomerulonephritis. And then we've also identified changes in other genes that regulate the regulators that also cause disease. So when a kidney biopsy is done, the diagnosis of MPGN can be made. We can also then look at the kidney biopsy and make a diagnosis of C3 glomerulopathy, if there's no antibodies there, but there is complement there. And depending on the electron microscopy, we can then divide that into dense deposit disease or C3 glomerulonephritis. And clearly, the cause of this, if there's an antibody that's causing activation of the alternative pathway, the treatment for that might not be the same as if there's deficiency of a protein that normally regulates the complement pathway. And obviously, if there's a change in a gene, this has implications for whether there might be other members of the family at risk. And that really depends on the nature of the change of the gene. So, what I hope I've explained is why we call this MPGN, what MPGN means, and how we make this diagnosis, how the terms dense deposit disease and C3 glomerulonephritis fit into this disease category. We can tell from the biopsy whether this is likely to result from an antibody production, so generalized increased antibody production, or a change in a gene that regulates complement. We can also tell how severe it is. So there can be mild MPGN or there can be severe MPGN just by the extent of the changes in the kidney biopsy. And that's a subjective description that's made on the basis of each individual patient by the person looking at the biopsy. And we can also tell from the kidney biopsy how much scarring there is in the kidney. And this is important because it gives us some idea of what the disease, what's likely to happen over the course of the next few years for the disease. Are there any questions?
Sally, do you want to start?
Could you explain why people might know that they've got MPGN type 1 or type 2?
Okay, so type 2 MPGN is a synonym for dense deposit disease. And I should probably put that up because many people will have heard that. But they mean exactly the same thing. Type 2 MPGN or type 2 MCGN are the older names for what we now refer to as dense deposit disease. Type 1 MPGN really encompasses all the other types of MPGN, apart from the very rare type 3, which is slightly different. And the way that those were defined is actually where the electron dense deposits were on the kidney biopsy. So I think I had so type 1 just means these electron dense deposits are found on the inside of the basement membrane. Type 3 means that they're found on the outside, usually as well as the inside. And type 2 means that there's dense change actually within the basement membrane.
Hi, I was just wondering, why does the C3 actually stay in the kidneys? Is it because of the positive pressure? It's a filter, so it's being pressed against the filter.
So, I mean, that's a really good question, and it isn't completely understood why the C3 sticks to the kidney particularly. So one reason is that a lot of blood goes through the kidney. So a third of the blood flow through the human body goes through the kidney. So there's a lot of exposure. The second is that there's a very large surface area. The kidney is divided into these very fine capillaries. And the third, probably the most significant reason, is that the actual chemical structure of the basement membrane and the endothelium, the cells lining the blood vessels, we think is a little bit more sticky to C3 than surfaces elsewhere in the body. So once C3 is activated, it will tend to stick to surfaces, but for those reasons, it particularly sticks to surfaces in the kidney. Now, some patients with dense deposit disease, type 2 MPGN, will also have C3 deposition in the back of the eye. And that's presumed, well, we think that's because the structure of the blood vessels in the back of the eye, the very fine blood vessels in the back of the eye, is actually quite similar to the structure of the blood vessels in the kidney. It's rare for that to then cause significant problems just because the way that the eye and the kidney need their blood vessels is slightly different. But if you look with what we call an ophthalmoscope, which is a device you can use in the clinic to look in the back of the eye, in some patients with complement activation and C3 sticking in the kidney, it can also stick in the back of the eye.
Thank you. I've just got another one, actually. So as the C3 builds up, the filters gradually fail, and then the nephron basically fails and the tubules scar.
Yeah.
And where does the hormone management come in and the acid regulation? Is that, how's that affected? So
the kidney, when you're born with more kidney than you really need, both for filtering the blood and also for controlling all the hormone systems and the acid-base balance that the kidney needs to do. As the amount of kidney that you've got left gradually deteriorates, whatever the cause of the damage to the glomeruli might be, but in MPGN, because of complement activation and deposition in the kidney, as the number of tubules decrease, they have to work harder in order to do what the body needs. And once you get down to sort of less than 25% of the normal number, that's when some of the hormones, you don't quite make enough of them. And then when you get down to less than 20%, that's when you need help with hormone treatment like EPO hormone and vitamin D help. And those changes happen and can be treated with those treatments. When the scarring gets even more, then the kidney has difficulty handling the acid base and the salt of water, and then that's really when you start the patient needs help with dialysis or else a new kidney in the form of a transplant.
Thank you.
We were just told by the previous speaker of the development of a C3 inhibitor, or something, switch it off in the same way that there is one for C5. Is it simplistic to think that if that was brought to the market and patients could take that, that would be the end of the situation?
That's a really good question, and that is a sort of work in progress. So there are chemicals, drugs in development that do target C3. Whether they will treat patients with MPGN, we obviously all hope that they will. It's certainly possible, but in order to know that, there needs to be clinical trials where patients with these diseases are given the drug or a placebo to find out if it actually makes a difference. Before that can happen, we need to show, or the people developing the drugs need to show that the drug is safe. So, and that involves giving it to animals and seeing what the effect in animals is, and then giving small doses to healthy people, seeing what the effect in healthy people is, and then before that they can be used in people. What we hope is that those therapies will be safe, that they will be effective, and that they will be in clinical use in the near future. But at the moment, there aren't any licensed C3 inhibitors that we can use in the clinic.
So do you have any time frame on that? Or?
Well, a little bit depends on what the outcome of the safety and the efficacy, the effectiveness studies are. I mean, if they all work beautifully, then I wouldn't have thought more than 5 or 10 years. If, on the other hand, depletion of C3 causes the immune system to become too weak, or if the drugs aren't effective at actually depleting C3, despite that's what they're designed to do, then obviously the time frame could be longer. But there are the technologies that exist to develop these drugs, and they are definitely being developed.
Okay, thank you.
We have the microphone down here.
Could you talk a bit about these diseases coming back in transplants?
Yeah, so as Matthew mentioned, the changes that we see in MPGN, dense deposit disease, and C3 glomerulonephritis quite often result from changes in the person's body, not just in their kidney. So increased antibody production, that's not caused by the kidney is just seeing the effects of it. And these complement regulating genes are usually made in the liver, not the kidney, and they circulate in the blood, and that's where they act. And the antibodies that stabilize the complement alternative pathway are also made by the blood cells. So after the kidney's failed, putting a new kidney in, it will still be exposed to the same damaging complement dysregulation that was present that caused the initial kidney to fail. Now, the ways round this, well, it might be that the pace of the disease initially was so slow that actually a kidney transplant lasts for a very long time. And there are some people with a particular type of C3 glomerulonephritis called CFHR5 nephropathy, where the disease does recur in the transplant, but it recurs so slowly that actually people who've had kidney transplants, they last just as long as they would as people who've had kidney transplants for other purposes, 20 years or more. In other situations, if there's a lack of a complement gene that's normally made in the liver, the only way to correct that lack would be to do a liver transplant at the same time as the kidney transplant. Because these diseases are so rare, it's not really known whether that sort of strategy actually solves the problems, or because obviously it causes other problems, which is associated with having a liver transplant. So disease recurrence in transplants is a real problem. It might not be a problem in everybody. So about half of people, the kidney transplant will last for over 5 years. But it's certainly in a proportion of patients, the disease comes back in the kidney transplant and causes loss of that kidney transplant.
One here and then one last one over here.
Is there any possibility of regenerating any of the tubules? Can a kidney regenerate itself if you were able to dissolve these dense deposits out? Could it recover to a certain degree?
So when the glomeruli are lost, the filtering units, when they're lost, they don't regenerate. When the tubules are lost, they can regenerate. The problem is that in MPGN and related diseases, the reason for the tubules to be lost is because the glomeruli at the top of each of those tubules has been lost. And because the glomeruli don't regenerate, those tubules won't regenerate. So the answer to your question is that when we see the scarring in the kidney biopsy, we can say that that scarring is a scar and it's not going to regenerate.
My question follows on from the recurrence question. Do you think that, when we presented, we were probably stage 5 with about 5% of renal function, went straight to dialysis, were transplanted in December 11, and we were told in March that post 15 months transplant, we now have recurrence. So my question is, do you think, because when Lewis presented, he had severe renal dysfunction, the speed, do you think that is an indicative indicator that his recurrence would be back very quickly post-transplant?
I mean, that's a really good question. I mean, we know that in patients who've had the disease all their life and they develop kidney failure later on in life when they're adults, the recurrence does tend to be slow. And those are the people for whom the kidney transplants last for a longer time. The people who had more severe disease, there may be reasons why that happens. So in very young childhood, people are more susceptible to certain types of infection. And those types of infections may stir up the complement system and cause a lot of kidney damage in early childhood. When people are a little bit older than that, they're not so susceptible to the same infections. So just because there's been rapid disease progression early in life, it doesn't necessarily mean that there'll be rapid progression in the second decade of life. So the answer is there haven't been enough patients for us to be able to give a really clear-cut answer, but we do know that it's variable, that some people who've lost a kidney rapidly have a kidney transplant that lasts a long time, and that other people who lost their kidney rather slowly, sometimes it does come back quicker. And the only way to know is to see what happens over time in the kidney transplant. I hope that answers the question at least partly.